This is Douglas Drake with Clinerion in Basel, Switzerland. Welcome to Bio and our presentation. I want to introduce you today to Clinerion, based in Basel, Switzerland, and my talk will be on enabling an artificial intelligence and machine learning infrastructure to improve patient care and outcomes by improving healthcare data analytics. Clinerion is based in Basel, Switzerland. We've been working with electronic medical health records since 2013, and we leverage real-time, real patient, real-world data through our network to enable clinical research and real-world evidence. Our goals are to use digital data to improve data care, patient care, as well as patient outcomes globally. And you'll notice that we have a variety of different validations and certificate, and I add that data security is one of our key priorities. We work with the 5 dimensions of EHR data, looking at demographics, procedures, diagnosis, laboratory results, and medications. And what's unique about Clinerion is because we're doing this across almost 23, 25 different languages, 19 different countries, we're working with healthcare records in all types of standards, languages, formats, and bringing those up into a single international ontology that we can query quickly and uniformly. This makes us unique in actually really bringing together all the different healthcare forms universally and internationally. And also, I add a 6th dimension here, time, because this allows us to actually follow patients and patient care through their patient journey with a disease or medication. We do this in process with our hospitals where we work with them in partnership. This is showing you the hospital network here in this diagram. The hospital information system is gray in this box, and you'll notice that we have then our ANID server for anonymizing the data. That also always stays within the hospital firewall, the gray box. Hospital then the rights to query this anonymized data, and that way bring back aggregate results showing where patients are and looking at care metrics. The hospital in turn has the ability to use our framework to then query their own data and use this for stratifying their own patient care. This is our hospital network. Well, as I mentioned, almost 35 million patients, starting in Switzerland and then expanding into Eastern Europe. We have good populations in Poland, Serbia, Croatia. As you'll notice, we're also expanding into Georgia, into the Ukraine, and then we also into Middle East, including Saudi Arabia, Turkey, United Emirates, and then thirdly into South America, Brazil, and most recently Colombia. So you'll see we have a very unique coverage and very unique also in terms of language and expertise. This allows us to really work with a variety of different healthcare professionals in really looking at patient care in a global fashion. We can use this to look at predictive modeling, looking at both care metrics, as you see here in this example, longitudinally going back in some cases 2000 to 2002 for this example, and then looking at therapeutic insights, frequency, medications, and procedures, and seeing how patients are being treated in each of our different countries and specific hospitals. This allows us also to enable HER metrics, as well as also look at compound-specific usage, as well as also look at demographic treatments. I want to give you a few examples. This first one is of multiple myeloma, first instance 2018. This particular study we did, you can see that we can find, based upon WHO published numbers, in Turkey, one of our largest populations, we could find 70% of the patients and just less than 20% of the population in our hospitals. In Brazil, we could find 15% of the patients and just less than 3% of the total population. This means that we can really enrich for patients that are seeking treatment or are in treatment and really help you find good statistics across our network and across our countries. This is further showing you this example of multiple myeloma, and once again from instance of 2018, where you can see the demographics, in this case looking at the age as well as sex, and then also looking at Charleston comorbidities to look at risk scores, and then also looking, as here, looking at administered therapeutics, as well as also treatment regimes to understand what are the most common types of treatments and how bortezomib in this case are being used in a number of different possible treatment combinations. This gives you indications in a specific example in Turkey of how multiple myeloma is being diagnosed, treated, and then obviously the risk score around these patients, and obviously outcomes. I want to give you a second example looking at severe asthma in the UAE, and this example is looking at type 2 inflammation, and in this case looking at one of the biomarkers, phenylnitric oxide, and we can get down to the granular level looking at the laboratory results to identify specific cohorts, and then looking at exactly how those cohorts are treated. In this case, looking at patients that have less than 20% parts per billion phenylnitric oxide as part of their type 2 immune response. And this shows you here the demographics, the lab tests, the comorbidities, as well as also the administered therapeutics for these patients. And we can then follow them in their treatments and see how these can be then mediated. A third example I want to show is actually COVID, which many of you are aware of, obviously. But EMR data, the real data out of hospitals, was actually one of the few and only sources to really follow the pandemic. And we were at the lead of this within our network, showing what patients were being affected, what their risk factors were, comorbidities, what type of treatments they were receiving, and what obviously was helpful, and other helping identify also risk factors, as well as also prioritize patients for immediate treatment. And this is a real value in our network. We're looking now, as you see, with a global metric to obviously looking at a pandemic. And this becomes more and more that real world view is really important for a complete worldview to a disease and also treatment modalities. So I want to talk a little bit more about obviously how we're enabling our network further by adding AI and machine learning capabilities. And we're doing this here in Switzerland in combination with two leading academic institutions, the Berner Fachhochschule and the University of Zurich, to build an infrastructure within our PNX to enable better modeling and also machine learning capabilities. This is being done, as you see here, once again, going back to the architectural diagram I showed previously, by building into, once again, the hospital environment, a new capability called this federated machine learning server that allow us to do more statistics, more modeling, as well as also enable remote learning capabilities. And this will eventually be developed into a federated machine learning project across disparate hospitals at the same time. This idea of this is to really learn more. There's two metrics to this, really helping to, first of all, better understand statistics and looking at time indexes and detection of patterns, as well as also scripts, and looking at really the ability to look at all these different capabilities. And then in addition to this, be able to deploy self-learning models that can be trained and then refined and then deployed subsequently across multiple sites in a sequential fashion. And this is going to be important as we go across the hospitals from one country to the next, that they then can learn the style of training or learn the style of healthcare and then readapt that model as it then progresses into that country and across countries. I want to give an example of also how this is being used. This is an example of working with rare diseases. In this case, as you may know, rare disease patients many times are not commonly diagnosed. Many may not be diagnosed their entire lives. And so we're working with a number of sponsors to help find patients, especially in our network coverage, that have never been correctly diagnosed for rare diseases, and that way enable better treatment and better care. And in this case, we can develop actually cohort models looking at the phenotypes of disease patients, and especially looking for patients that have not responded to traditional treatment, be able to identify these patients, flag them, and in this case, we can then go back, get an ethical committee approval with the hospital to do an outreach to those patients, have them diagnostically tested, and then hopefully put on the correct medication if the proper diagnosis is made. And this will enable a number of patients for the first time to receive the correct medication. We're doing this in this case here in Turkey, but we're also doing it in other countries, looking at Pompe, Gaucher's, Fabry, as well as MPS 1. This is an example of the same thing, but adapting it also in the UAE, where we've obviously done this and now building this out to now do the outreach to these patients and actually do the diagnosis and confirmation. And this can be done then in an iterative fashion across multiple countries to adapt these models and improve them. So I want to take the time to thank you again for your attention. And my point here is to show you how a network of hospital information systems using EMR data can be used to better care for patients, treatments, better model disease modalities, as well as also find patients and help better diagnose them. Thank you very much for your attention.